I think we'll get 2 minutes on the clock and your time starts now. All right, time is up. Let's have a look at what some of those answers could be. Now, as we've expressed before, knowing what your DSM criteria are for meeting certain diagnoses is very much fair game in the exam. And as well, being able to apply those nuances, in particular things like timeframes, is incredibly invaluable, not only for making an appropriate diagnosis for your patient, but getting through these exams here, in particular KFP. Now, there's a couple of kind of generic things you'll always find in these mental health questions, and those are usually along the lines of, is there a family history of mental health disorder? We do know that there is potentially going to be ongoing mental health conditions that run through families, puts them at significantly increased risk. Is there a history of illicit drug use? Now, this one's also in particular importance simply for the fact that a lot of diagnoses require there to be no concurrent illicit drug use or no other kind of explanation along those lines that would preclude diagnosis. I think if you were to have something along the lines of here, experience delusions of grandeur, paranoia, or thought insertion, or broadcasting, anything in that kind of bracket there, they would probably be grouped together. Of course, in the actual exam, I wouldn't be putting ///. That would definitely fall into the realm of overcoding. But if you're having something in that kind of bucket, I think you'd be definitely getting a mark there. Again, we're coming into some of those time frames. Have these delusions been present continuously for the 2 months? So you're establishing time frames here, and it's the continuously that is not specifically stated in that history there. This can be particularly helpful for differentiating things like schizophrenia from schizoaffective disorder, for example. Now, of course, tying into that exact same thing as well is the symptoms of mood disorders being present for a majority of the active portions of illness. So again, this is one of the really important differentiators from things like schizophrenia and bipolar and schizoaffective disorder. Has there been a period of disturbance for at least 6 months? Again, one of the other diagnostic criteria. And has there been impact on her relationships? This is one that isn't DSM, but you'll always find this as one of the answers for RACGP questions. Hopefully that makes some sense. Now, of course, we have some excellent answers in here as well. To be really, really nitpicky, because that's kind of the point of me being here, really, recreational drug use, fantastic. Low mood, I would actually be specifying in not just low mood, but time frames, because one of the things that has been brought up here is that it does specify, where is it, if I read through, she denies changes to her mood. And so that would be a little bit risky unless you're kind of specifying something in particular about that mood change there. Chronic headache isn't on this list, but actually I would include that an excellent pickup here, because that would also be excluding other causes of personality change. One, of course, would be intracranial abnormalities, intracranial lesions. Good, well done. Thinking outside the square, good. All right, let's get that one off there. And of course, there's follow-up questions here. So let's get another 2 minutes on the clock, and your time starts now. All right, time is up. Let's have a look at some answers here. And you will get questions like this where it kind of says, okay, pretend every other bit of information you get isn't actually that relevant. All those questions you've asked probably don't contribute too much here. What is going on? And you can see here, and I want you to kind of pull back the curtain a little bit, you can see they're really trying to shoehorn you down that kind of mental health pathway. And so often it can be good to follow that paved road, so to speak, and focus in your answers on that, particularly when you only have, say, 4 options here. Now, lots of things that this could be, and based on timeframes, based on mood changes around some of this hallucinations as well, I'd be putting high up on this list something like schizoaffective disorder. And with the information we have so far, it would be very difficult to actually tease this apart from something like schizophrenia, and probably a little less so along the lines of something like bipolar disorder with psychotic features. Now, this is one of those instances where being really specific, being really niche into showing your consultant level knowledge gives you those extra marks. So specifying with psychotic features is more likely to get your mark. I think if you just put bipolar disorder, you're probably not going to get those marks there because there's not quite enough specificity to that diagnosis. Likewise, this could be something like depressive disorder with psychotic features would get you a mark. I don't think personally that not having the psychotic features there would actually give you that diagnosis. Now, we do have a bunch of excellent answers coming through here. Let's step through what some of these could be. So, here we've got manic episode of bipolar, fantastic, and I really love, again, how specific you're being. Depressive episode with psychotic features, chef kiss. Space-occupying lesion, yes, yeah, I think that definitely could be in there. Not on this list, but again, as mentioned before, if there are headaches present there, it would be one of those things you would want to be further investigating. And schizophreniform disorder, yes, there's enough boxes being ticked here that I think that probably would be fair game. Good. Now we've got some more answers here of intracranial glioblastoma. Really good, and in particular here, not only have you you've been super specific of one particular form of intracranial lesion, which again, fantastic work there. Depression with psychotic features, tick. Schizophreniform disorder, beautiful. Bipolar affective disorder, again, just to really kind of hammer it home, I really would try and put in with psychotic features just to add that specificity to it. Question here is, doesn't schizophrenia need more than 6 months? And the response is yes. But this is where you would try and tease out more information here, and it would be one of those ones that you would be wanting to further investigate. Here we have question 2 mentions, a question mentioned 2 months of delusions. Wouldn't that be too short for schizophrenia? Yes, so again, kind of factoring into that same one there. In this instance, I think schizoaffective disorder would be much more likely. What I would want to tease apart here is, have there been previous instances where there's also been some of these delusions, and what kind of time frame have they occurred over? This is tricky because they've specified in here that any further information obtained is non-contributory. And so you do have to have a little bit of kind of creative license in terms of, well, does that mean that they haven't been able to give you any kind of legible or sensible responses? And tying into that further history would probably tease out a little bit more. But yes, correct in terms of diagnostic criteria. I don't think I would definitively exclude schizophrenia. And the other kind of side to that coin is, maybe you actually just need to wait a bit longer until you tick that kind of 6-month mark, but that still would be managed as a schizophreniform type disorder or schizophrenia type disorder. Hopefully that makes sense. Okay. Of course, we've got a final aspect to this question here. Let's get 2 minutes back on the clock then, and your time starts now. All right, time is up. Let's have a look at some answers here. And I'll preface this one by saying that this is probably not a question you're going to see in the actual exam. And I've intentionally not put down a list more than 3 here because this is going to be a state-specific thing. And so I think it would be probably a little bit unfair on the college to be asking in a national exam information that has so much state variability. I've got some of the answers here for Victoria, for example, but if this isn't something that you're particularly familiar with, I think it's actually really handy for you to actually look it up and have a good working knowledge of what is actually your state's criteria. Now, there are some common things shared amongst all of these, and of course, number 1 is the person has to have a mental illness or appears to have a mental illness. This is a really important little caveat that's thrown into pretty much every state's mental health act, in order to make sure we're only actually using these powers on people that have mental health conditions. In Victoria, and again, this is one that is actually common amongst most states, is that the person appears to need immediate treatment to prevent serious deterioration in the person's mental or physical health. In Victoria, that is separated out as well into an additional aspect of requiring immediate treatment to prevent serious harm to the person or to another person. And this is something that often paramedics will have to use this criteria to bring someone in under a section if the person, say, putting themselves at danger, be it running through traffic or wielding a weapon, things like that. The person can be assessed under an assessment order, and this is something that I think sometimes gets a little bit tricky because the patient may be acutely psychotic, they may be substance affected, and it's important to note that in that condition, if we believe that there is substances on board, they actually can't be assessed under a compulsory assessment order until they've had a period of observation, they've been stabilised and medically cleared to be able to have that assessment occur. Now, that doesn't mean that you can't actually place them under a assessment order requiring them to be brought in for psychiatric assessment. It just means that they can't actually have that assessment undertaken while they're substance affected. And of course, a really important one that really has been kind of hammered home in Victoria at least is that there is no less restrictive means reasonably available. Reasonably, what does reasonably mean? That could be argued, to enable the person to be assessed. This is actually a really powerful kind of addition to the Act that gives the patient a lot more control and autonomy to be able to say, I'm going to choose to do this voluntarily so that they don't have to have certain freedoms, certain liberties taken away from them. You might argue it's kind of semantics that, you know, if they don't agree, then they're going to be forced to agree. And in some regards, yes, that's true. But if you speak to patients that have been in these kinds of circumstances, I think it is incredibly empowering and humanising to still be given that opportunity to engage somewhat on your own terms. So again, if you haven't actually had the chance to read through your state-specific legislation around this, I strongly encourage you to do so.